Okay, well, it is a little afternoon, and we're ready to start the third of the GSA COVID-19 conversation series. Let me turn it over first to Elizabeth Sobchik from GSA, who can tell us a little bit about the conversation series, the GSA COVID Task Force, and introduce today's webinar.
Thanks so much, Dr. Albert. Welcome, everyone. We have a little bit of housekeeping to go through first. Please introduce yourself in the chat. We'd love to know who's here. We also will use the chat box throughout our presentation so that you can comment or ask questions. You can also flag any technical issues that you're having, and we'll try to help resolve those. Our conversation is being recorded today, and we'll archive that on the GSA's website. If you like our format, please join us and invite friends to join in future conversations. We have one coming up in October. And please keep yourself on audio mute as we do the beginning discussions. So how did we get to this point today of hosting COVID conversations? Well, in March of 2020, GSA pulled together a COVID-19 task force when we realized that the pandemic was disproportionately impacting older adults. The task force represented multidisciplinary experts in a variety of fields, and we really tried to help them advise us on staying apprised of the pandemic, to prioritize, to create tools and resources, and to support our members during this time. One of the pieces that the task force worked on was a specific research agenda. And so you'll see the 12 areas here that they prioritized after speaking with GSA interest group leaders and other leadership throughout the organization. These 12 areas had many pieces sort of underneath them to give definition to what these mean and where the specific pieces were that we need more research attention given to better understand how the pandemic is impacting older adults. You can see the full citation down at the bottom and find the full article and details there. The journals were also publishing quite a bit on the pandemic, and so were some of the first to publish on what was happening. There are a number of special collections, virtual collections, and articles, individual articles, detailing a variety of aspects of what was happening with older adults in the last year and a half. You can see the links here and visit those articles as you'd like. But from all of these articles, we've now pulled together our COVID conversation series to pull together authors who are in a couple of different topic areas and publishing on topic areas to share their research, to answer questions, to discuss what we know and what we don't know and what we still are learning, and to use that and apply that in the future. So we've had two so far, and we're on our third now. There's a fourth one coming up in October, as I mentioned. You can register for all of the conversations at that link at the bottom of the screen. And you can also view the recordings if you've missed some of our past conversations. They've run each about an hour long and have shared some really wonderful things. I've learned quite a bit listening to all of our authors speak. And so with that, welcome to our panel today. We're so glad to have all of you. I will turn things over to Dr. Albert to get our conversation started. Dr. Albert, I'm sorry. I think there we go.
I was on a webinar recently where someone just said, I was just testing the system. Okay, so I apologize. Anyway, it's great to have you all with us. I'm very excited to have our third conversation. We have a terrific panel with us today representing really international gerontology. Liat Ayalon from Israel, Bar-Ilan University School of Social Work, and Brad Meisner, York University, Canada, Kinesiology and Health Sciences. Really terrific. I'm Steve Albert. I'm in the Department of Behavioral and Community Health Sciences at the University of Pittsburgh's Graduate School of Public Health. I've had the pleasure and honor of hosting a number of these conversations. And throughout, we've been very interested to figure out what we have learned from this pandemic. How might gerontology have to change in the way we do things and that sort of thing. And we've really covered some fantastic ground. So today's focus is what worked and what didn't work, in particular for the mental health of older adults during the pandemic. And it's, I think, a challenging question. While the pandemic is mostly under control now for older people in high-income countries, that's not the case more broadly. And while over 80% of older people in the US and in the more developed countries have been vaccinated, we're not out of the woods yet, as we say. We still have emerging variants. And despite the reduction in the risk of hospitalization following vaccination, we're still seeing increases in caseloads in emergency departments and in hospitals. The path to the vaccines and the high level of vaccination and reduced hospitalization among older people was not easy, and the fallout from the earlier pre-vaccine period is still emerging, I think. So in this conversation, we'll examine false steps and how we got to where we are today to protect older people and some of the challenges to get there. Some questions I think our two authors and researchers can address are: what role did ageism play in attitudes toward protecting older people? And how did older people fare in the isolation and restriction of behavior that we all had to adopt? Apart from these restrictions and visits from family and friends, especially in long-term care settings, what was really challenging for people and what made this difficult situation better or worse? So that's the kind of thing we're going to look at today. I'm going to begin then by letting our two speakers introduce themselves and talk for a little bit about some of the research they've done in this area and related areas. Both have a long research pedigree in these sorts of questions. So Dr. Ayalon, please, if you would.
Sure. Hi, everyone. My name is Liat Ayalon, and the truth is that a major area of research of mine, even before the pandemic, has been the topic of ageism. And Steve and I just had a conversation about the term ageism in Hebrew. And the truth is that this term was unfamiliar to me up until about 10 years ago. Even though I was teaching gerontology, I was doing research in the field, but I still was not aware of the term ageism in Hebrew. And only when I actually became aware of the term in Hebrew did it become a real concept for me. And I think that my entire teaching and research agenda has changed as a result of that. So once I really had a concrete concept in my mind, I was able to change my thinking and really understand how ageism really affects my teaching and how it affects my work in general with other people and my research agenda. And I remember that maybe during the first or second courses that they gave in the field of gerontology about 15 years ago, I would devote maybe 10 or 15 minutes to the topic of ageism, use the term in English, and move on to the next thing. And then when ageism really became a concept that has a meaning to me, I devoted maybe the entire, almost like 2/3 of the entire course to the topic of ageism, because I really realized that the rest is something that people can acquire elsewhere. They don't really need the knowledge, they need the attitude change. So that's what I've been doing for, I would say, about a decade now. I used to lead a group of researchers in Europe. I received funding from the European Commission to lead the European group of researchers and also policy stakeholders in the field of ageism. And we did that for 4 years. And as a subsequent step, I'm currently coordinating a PhD program on the topic of ageism, again, funded by the European Commission. It has 15 students that come pretty much from everywhere in the world. And they are also located in various universities, but also policy institutes in Europe, with the idea that Ageism has real life impact on all of us, and it's really not enough to do great research and keep it buried in the gerontologist or other excellent journals. But really, the idea is that we need to be able to speak with policy stakeholders and vice versa. My experience has been that it actually has been quite challenging for me to attend policy events initially, because they speak different language, they think in a different way. And I really tried this PhD program to serve as a bridge between science and policy, so that research can inform policy, but also policy stakeholders can come to us and tell us what it is that we should be focusing on and can be relevant for their agenda. And I would say that the pandemic really has been, I don't know if it's a good thing or a bad thing, but really has made ageism an extremely prominent topic, because just like it's a pandemic of COVID, it's also a pandemic of ageism. And I've been doing quite a lot of research relevant to ageism during the pandemic, but also unrelated to the pandemic.
Excellent. Great. We will come back to all of these topics, and you are in a very good position to teach us about ageism. Okay, Dr. Meisner, please.
So good morning or afternoon or evening, depending on where you are tuning in the world. And so first I'd like to acknowledge and thank Dr. Albert for the invitation to attend this COVID conversation. I'd also like to say that it's an honor to present with Dr. Ayalon. I followed her work before the pandemic, and of course I continue to follow her work during, as she's quite productive in this area generally, but especially during the pandemic. And thank you all for being here. So I'm coming from Canada, and so I'm an associate professor in the School of Kinesiology and Health Science in Toronto. And I'm also a member, a long-term contributing member to the Canadian Association on Gerontology. I'm also on the editorial board for the Canadian Journal on Aging, which is part of the Canadian Association on Gerontology, similar as the gerontologist is part of GSA. Generally, my research, ever since my PhD, and actually my master's, was focusing in on critical health psychology, if you will. And so I want to challenge the common misconceptions that normal aging is inevitably associated with decline, disease, disablement, and inactivity. And as a result, a main theme of my work over the last 10 or so years as well has focused in on ageism in its multiple forms, and also in multiple places and contexts in which it manages to find itself. So when COVID was a thing, when that started to go viral, no pun intended, around the world, my interest switched to social media. And so not only as a knowledge consumer, I was interested in social media to learn about what the experiences are of COVID around the world in different countries. But what struck me the most was how social media could be used as a tool to foster social connection while simultaneously allowing us to physically distance. And so I saw it as a really cool opportunity to see how social media, such as Twitter, Facebook, TikTok, whatever you use, if any, how can this be used to our advantage in a time of crisis? And unfortunately, and perhaps not surprisingly, when you find yourself in social media, I became keenly aware, perhaps because I'm an ageism researcher, that social media was being used as a source for pretty strong hate speech against older people. And that's what got me attuned and started to write about some of the trending topics around COVID and aging, and so how the virus was being labeled as the boomer doomer, or the senior deleter, the elder repeller, and all of these other terms. And the one that stuck out the most as a trending topic in March of 2020 was boomer remover. And so this is the idea that the virus is somehow designed to get rid of the older generation in a way that serves younger people in terms of, creating more job opportunities and, alleviating stress off of the tax system, and all of these rather atrocious things that were being said that represents population cleansing and genocide based on chronological age. And so I wrote a piece, and that was published in the journal Leisure Sciences where, I just outlined how social media is being used as a tool for ageism, hostile forms of ageism, but then also how this ageism is quite political in its nature in terms of working against older people for the benefit of younger populations. But also when I was preparing that article, focused more on hostile types of ageism, most of the research and most of the public discussions in the mainstream media was about hostile forms of ageism rather than other types of ageism, such as so-called positive forms of ageism. And then that got me interested in aspects of how compassion, so-called compassion and good intentions to take care of or protect older people also represents some pretty gross generalizations around what who older adults are, their capabilities, their actual biological risks. And so I started, kind of trying to balance the discussion around hostile as well as compassionate or benevolent forms of ageism. And so I published another piece, which is part of the special issue in the Gerontologist around compassionate ageism. And we'll talk a little bit about that later on.
Terrific. Excellent. Well, I'm really excited to hear where our conversation goes, and I'll throw out some questions to both of you, then to each of you. And of course, anyone in the audience, if you'd like to put a question into the chat box, or at the end, we'll unmute you and let you talk as well. And you can direct questions directly to our speakers. So just to set the scene again, let me throw a question out to both of you. Why do people continue to think of COVID as a disease of old age? The mortality now and most of the hospitalizations are not older people, at least in the United States. And yet we still think of COVID as a disease of old age. Is that appropriate, or what do you think is going on with that? So let me try that out with you. Liat, do you have a thought about that?
Sure, I have a thought about that. I actually remember the first time that I learned that chronological age is an independent risk for COVID-19 mortality and morbidity. I thought this was a mistake. I remember reading the WHO pamphlet that explains about COVID, and I thought they were being ageist because this is really against anything that I've learned, that chronological age is just a number, and that there are many other types of age, like biological and physiological age. And there is such a heterogeneity that I expected it to come along in their explanation, but it wasn't there. And even though some gerontologists were really saying, oh, but this is really, this is not true, this is not the case, I remember people from WHO coming back and saying, no, this is the case. Chronological age is an independent risk factor. And I think that this message has really framed the entire population of older people, again, as a group, as a homogeneous group, and really has stressed the fact that chronological age has a meaning here, at least with regard to the pandemic. Now, I know that things are changing, but still, as far as I know, chronological age is still considered an independent risk factor, unrelated to all other medical conditions and so forth. So I think this really has put ageism on the spot, because it really defines older people by their age, and it also associates older people with, I think, two concepts. One is the vulnerability concept, because it really says chronological age is a risk factor. Older people are at risk, they are more vulnerable than others. And also the burden, I think, concept, because at times of scarce resources, and we have seen that, and actually we're still seeing that, there are scarce resources to some degree, whether it's vaccination or vent machines or PPE or whatever. We have to decide how to divide the cake, basically, and it cannot go to everyone. And then we have to decide. And in a healthcare system, and I think in the US it's the same as in Israel and as in many other countries around the world, the healthcare systems have been neglected for many years. And this is the payoff time. Now we see this neglect, and we really have to divide scarce resources across different groups. And older age has become associated with asking more than its share in the population. And this, I think, has been instigated a lot of resentment. It really has strengthened people's stereotypes towards older people as vulnerable and also as a burden to society. I think these are two major stereotypes that have become quite prominent during the pandemic.
Very interesting. We'll come back, I think, to whether the COVID pandemic unleashed an ageism pandemic, as you've said. Brad, do you want to weigh in on this question about aging and COVID as a disease of old age?
Sure, and I echo everything that Dr. Ayalon had said. Those were some of the first things that came to my mind in terms of the public health messages that was coming out of the World Health Organization around chronological age being a profound or a robust risk factor, and therefore anyone age 60 plus, you should avoid engaging with them, or they should be staying at home. A lot of this prescriptive recommendations and even mandates based on chronological age, when anyone in gerontology knows that that's a measure of time, not a measure of actual age or biological age, which is what is associated with these biological risk factors, especially in terms of the immune response or the immune system's ability to respond to a virus. But the fact that the World Health messages were adopted internationally very widely, very consistently, in terms of framing elderly people as vulnerable, well, that maps quite closely on pre-existing stereotypes that generally people have about the aging process. And so aging and disease has historically been associated because of ageism as well as ableism. But this virus, I think, really tied those two concepts closer together because of the widespread consistent messaging around older people being vulnerable and therefore needing to take extra precautions when working with them, or they need to take their own precautions when living their own lives, right? And I think the crisis that happened in long-term care around the world in terms of mortality due to the virus and long-standing issues in long-term care systems, not only in Canada, but internationally. The fact that long-term care is thought of as a place where older people have to live, and then seeing the mortality rates as high as they are, I think people saw that as, implicit evidence to amplify this idea that COVID is a disease for older people, when this really does a disservice for younger people, right? If we want to take a lifespan perspective, if younger people are assuming that this is a condition that only older people need to be worried about, then they're going to be less likely to take it seriously. They're going to be less likely to take precautionary measures. We know with the Delta variant that the possible outcomes, medical outcomes, are much higher for younger people than they were for the original virus. And so there are consequences to even younger people for this chronological age messaging around the virus, that if it's being framed as an older adult condition, well, what harm does that do to younger people as well, right?
Let me ask both of you, were you surprised, or could you have predicted this this pandemic of ageism, or what was it, more than you would have expected or less than you would have expected, or is that just not really a fair question? What do you think?
I can say that I was surprised, even though I'm not an optimistic in my personality. But in 2016, the WHO started a campaign to combat ageism, an international campaign. And I really expected this campaign to change the world. Mm-hmm. And then the pandemic has arrived, and I have to say that personally, I was very surprised. But then when you think about it realistically, it makes sense that this pandemic of ageism would splurge again as well, just because I think that at times of scarce resources, and if we go to different theories, there is this competition over these resources. So it's quite clear that if age becomes a dominant narrative, it will result in different age groups competing against each other and pitting against each other. Also, I think that the association of older people with death reminders, again, is something that is likely to increase our death anxiety and might again result in higher levels of ageism. So I think I shouldn't have been surprised, but I was surprised.
Okay. Brad, your thoughts?
Similar line of thought. I think as a person, I was shocked and disgusted, especially at the types of hostile ageism around that was even being discussed in some American politics around, older people should be okay with accepting the risk of death so that the economy can continue and that opportunities for their grandkids, aren't being taken away. And that to me was shocking at a personal level. And then as a professional who's aware of ageism in its subtleties, I really wasn't surprised. But that being said, I've been interested in social media for a while, and a few years before the pandemic, remember the term "okay boomer"? People were using "okay boomer" as a way to dismiss older people's opinions. So we went from "okay boomer," which is an indication that ageism, of course, it existed well before the pandemic, and the pandemic definitely heightened it and maybe even made it more severe. There's a difference between "okay boomer" and dismissing someone's opinion versus "boomer remover" when you're dismissing someone's life, right? There's a different severity around the symbolic meaning around these terms, which were prevalent before and during the pandemic. And I think the long-term outcomes of this, we probably don't really understand how fully at this point, and we will someday hopefully understand the true impact or the full impact of this connection between disease, death, and aging,
Right.
more closely tied together than perhaps ever before.
Right.
Yeah.
We had a Texas legislator who said older adults should just accept the fact that they are at risk of dying and they are not worth the cost of an economic lockdown. They should just get out of the way. And if that means death, well, that's unfortunate. But so there was the idea that a subtle wrinkle on ageism is that older people should accept this approach. And Dr. Ayalon, you've called it a self-sacrificial quality of some sort, that older people should just accept the idea that they are less important to some extent. Is that a fair way to speak about this attitude?
Yeah, I think that we know that ageism is not only directed by others towards older people, but also by older people towards themselves. And I think that people have internalized these messages. So you hear it from the governor of Texas, you hear it from the Prime Minister of the UK, you hear it from all over the world, messages that say that older people should step aside and not interfere with the natural course of the economy. And these messages are actually internalized and people operate according to them. I would say that these messages have been there all along. In the US, you don't have a mandatory retirement age, but in many countries, we do have mandatory retirement age that says exactly that. It says that older people should step away and give the right of the way to younger people, because now it's the time of younger people either to enter the workforce or to continue with their life while older people are physically distancing in place. So I think it's the same message that has been there all along. And people do internalize it.
Okay, good issue. Yeah, very interesting thoughts. Dr. Ayalon, you've talked about two kinds of a dynamic of what you call rupture and what you call response. So rupture is this physical disconnection and the disruption in routine treatment and the physical distancing and isolation. And response is dealing with this reasonably, coming up with alternatives to maintain connection. Do you have a thought on what would have helped in this whole process, or how well the older population and families fared with this stress?
Yes, actually, this is based on the study that we conducted in Israel in long-term care settings. And we interviewed both all the residents, and actually we were able to approach only continuing care retirement community residents. And we also were able to interview family members from various long-term care settings, assisted living, nursing homes, and CCRCs. And the family members and also the residents themselves' response was that of rupture, because many of them have felt as if life before and life after the pandemic was not the same. And in Israel, there was quite an extensive lockdown for the entire population, but this lockdown was actually prolonged and started earlier for all the people in long-term care setting, in an effort to protect them physically from being hurt. But obviously it had enormous mental health consequences, both to older people themselves and to their family, but also medical consequences based on the reports of family members and older people. And one response that family members took was to really try to negotiate the situation and to become more proactive in front of staff, because really it became very clear that staff had all the power during the pandemic, especially the first wave, in terms of controlling who's going to see whom and when, if at all, and really monitoring the entire situation. I would say that also residents themselves try to respond by actually employing a downward comparison and saying that their situation is probably not as bad as the situation of other people. But this attempt to protect themselves from the situation was not very effective. And I would say that most residents eventually reported quite severe distress. And many of them, those who, for instance, were Holocaust survivors, really felt like they relived the past, and they kind of met another pandemic after reliving for a pandemic in the past, hiding in the past, and being forced to stay in one place. And it all kind of brought back all these bad memories to family members, and caregivers were quite torn, because it's quite challenging to bring in a family member who has been in one setting for a long time and accommodate everything and accommodate home care during the pandemic. So yeah, it's been a challenging period, I would say.
Let me throw out to both of you a question. You know, there are some older people who are, I guess you might say, reasonably healthy and still very, very severely affected by the isolation from the lockdown, who insisted on doing what we might call risky behaviors, traveling on the bus, or insisting on going to a restaurant where it may not have been the best thing. Or I can think of one case where someone was celebrating their 85th birthday and just insisted that they would prefer to have their friends there despite the risk of COVID transmission. Is that a reasonable response to what we're seeing, or what would you counsel families that might have disagreement about the appropriate level of protection, in response to the forced changes of behavior that we saw?
Brad, would you like to answer first, or would you like to?
Sure. Well, and this is a loaded question, I think. It's a political answer, right? Like, we're talking about the idea that our thoughts and our goals for ourselves are necessarily being projected onto other people in terms of how they're going to live their lives based on our decisions. And really, when it comes to maintaining our agency and our autonomy with at any age, being told what to do is sometimes hard to digest, especially if you've lived your adult life not necessarily needing to listen to the opinions of others. Of course, the COVID situation is different in terms of collective action versus individual action. And as a result, there's a calculated risk that I think people need to go through in terms of, you know, who am I? What is my biological aging, as much as I know of it and what I feel about it? And then thinking more broadly around, well, what is the risk level in my local environment? And seeing the pros and cons around what sort of behavior can be deemed appropriate by me or inappropriate by me, rather than being told what is appropriate or not appropriate, inappropriate by others. And I think this has created a lot of tensions in terms of how families have experienced the COVID time, but also how older people might be experiencing reintegration, right? So now that we're no longer having to, you know, be isolated at home and hopefully we're vaccinated, then, well, that should give us a bit more freedom. That changes the calculated risk.
Right.
But are older people now reintegrating themselves because their risk is lower, but still experiencing age discrimination because people see their white hair and therefore you're at risk, you should be at home. You should still be isolated.
Right.
And therefore someone else's opinion is being projected onto older people, even though their risk might be quite low,
Right.
healthy, 65 years of age,
Right.
you know?
Right.
So I kind of danced around that answer a little bit, but I did that.
I think we have to factor in the mental health impact of isolation and somebody's own appraisal of their
100%.
risk and the cost of being cautious, maybe.
Exactly.
Yeah.
And that's part of that risk calculation, right? The risks of not integrating, the risks of staying home,
Right.
but also the risks of reintegrating and being discriminated against because of it.
Liat, do you want to add something?
Well, I can only add that I come from a country that pretty much controlled our behavior still controls, but even before that, like up until the vaccination, controlled even more. So I think that this decision was really non-existent because in many ways we were just forced to stay home, unlike the United States, for instance, for many months. So this is a little different, but personally, I would say that that mental health is as important as physical health. Definitely nowadays, when we already have the vaccination, and I think that we take risks all the time, right? We go and cross the street, and there might be a car that hits us. So it's pretty much the same.
Good qualification. All right, Brad, let me turn to you now. Tell for your American viewers, tell us a little bit about caremongering, which I don't think we understand here, or at least I had never heard that phrase until I read your paper.
Yeah, so caremongering is an example of the positive forms of ageism that I was referring to before. So rather than thinking of ageism as being negative and hostile, the boomer remover types of worldview that some people have, kind of the flip side of that is the recognition that age stereotypes are complex and nuanced, and you can simultaneously stereotype an outgroup, you know, as being high warmth. So a group of people that you want to engage with, that's likable, but also you can negatively stereotype them simultaneously in terms of thinking that they're dependent, or they're not as competent as you are, or as what your social group is. And this is, you know, stereotype, a content model or content theory, where older people, historically, there's decades of research that are showing that older people are typically rated as being high warmth but low competence. And when we see that pairing of stereotypes, we're more likely to display sympathy or pity towards those outgroups. And as a result, we might be offering helping behaviors or offering support and making generalizations around someone's age or how old we think they are based on their appearance, without really considering what their actual competence, abilities are, or whether they're interested in receiving our help, right? And so this is the idea that, you know, of compassionate ageism, you know, I see you're an old person. I come with the assumptions around you being frail and dependent, especially with COVID, telling me that you're vulnerable, right? You're at risk and you know, how horrible for this age group, and then offering support, right? And then in Canada, there was this push called a caremongering movement, if you will. And this caremongering was kind of the reversal of scaremongering. So a lot of people were trying to make a political statement around, you know, we're not like let's say the public health directives are creating stress and anxiety, which is influencing the population's mental health. So how do we combat that? How do we go away from or resist this idea of scaremongering due to COVID? And the resistance of that is the creation of a new word, caremongering. And there were on social media, many Facebook groups that were initiated across Canada and eventually internationally around people logging in and being able to post, you know, these are the sorts of things I can do for people, like get groceries, or I can pick up your prescriptions, I can do this and this and this for you. And, you know, overall, it was nice in the sense that we were creating community in a time of crisis, and we were offering support for people who needed it. But in some cases, we'll see that there was a bit of a misrepresentation of caremongering. There was a quote that was published in one of our national newspapers. I'm trying to find it here. I won't be able to find it, but the way caremongering was being described was, you know, in the time of COVID, we need to recognize that the most vulnerable population, you know, is our elderly. So this idea of not only labeling elderly and vulnerable, and the word elderly is problematic in its sense, and we've talked about that for years now, right? But the idea of our elderly, there's like a patronizing ownership of an age group that was emerging out of this caremongering movement that represented compassionate forms of ageism, right? We're making generalizations about an age group without knowing their capacities, their interest in receiving help, whether they want it or need it. And it was more of an assumption around what older people need in this time because they are all inherently vulnerable. When a lot of older people were quite resistant to this idea that, you know, I'm not vulnerable, despite the fact of what these public health messages are saying. Like, I am still a person. I don't need help. If I do need help, I have the ability to ask for it myself when I need it, if I need it, and stop making these ageist assumptions about me. And it was all over media and mainstream, where even though the good intentions of caremongering were there, and it did offer real tangible supports for some people who were interested and who wanted it, there was a flip side of that where it was being used and created the conditions of other more subtle forms of discrimination, which also impacts the mental health of older people during the pandemic.
Very nice. Well said. So what I'm hearing, I think, is that two essential features of ageism, or at least as applied to COVID, are the sacrificial quality that older people should admit that they're old and unimportant and get out of the way, and also this obligation to accept help whether you like it or not, because you need it. And these are two difficult things, I think, to combat, very deep-seated. And one question I would throw out to both of you, you may know that this is the Decade of Healthy Aging from the United Nations. And ageism is a key focus of the UN effort. In fact, a recent report has just come out about ageism, but I think it predates COVID. And do you both have any strategies, whether public health messaging or media efforts? What do you think is the right response to remove some of the paternalism from ageism and yet still allow the supports that older people may need in a time of pandemic. Do you have any thinking about this? What would you tell the UN Decade of Healthy Aging operation now? What have we learned from the pandemic that we need to change about ageism? Sorry to give you a difficult question. Liat.
Sure. So I think that, well, maybe what I'm saying is a little political, but I think that within the WHO, for instance, the group that has worked on ageism is one group, but there are many other groups, and they don't necessarily speak with each other or speak at the same level or the same language. So there are still terms that WHO uses, like premature death, which is a very ageist message, saying that premature death ends at 70, and after that, it's not premature death anymore. And other terms that are used, like the dependency ratio and so forth. And I think that the problem is that we don't really have a coherent message that comes from WHO, even though they have the ageism report, which is great. And they do have a team that works on the global campaign and very committed to that. It's still quite fragmented. And when it's fragmented in one setting, the setting that is supposed to set the tone for the entire world, we see the fragmentation all over. So I think this is the major problem. And when you think like a physician trained in medicine, thinking about chronological age in one way, and then you come as a social scientist and think about chronological age in a totally different way, and these groups do not necessarily communicate with each other, it's a problem, and the message is just not coherent enough. And I think this is a big problem.
So what I'm hearing is you think the UN needs to clean its own house first?
In a way, yeah. I think they need to get rid of all the ageist terms that are being used. You know, when I was at the UN, on each of the doors there is a sign saying no to sexism. I would like to see the same sign saying no to ageism, and it's not there yet. And not only is it not there yet, they have a mandatory retirement age. So I think that it's very difficult to come up with a global campaign to combat ageism in a place that is still practicing ageist practices to some degree.
Okay. Brad, any thought?
Yeah, that's an excellent point. I think part of what the response should be or could be more of would be listening to older adults' voices, right? Like, I think a lot of these public health directives and decisions that are being made, you know, at the World Health Organization, UN level, and even, you know, within countries and states and provinces and what have you, like, these are directives being made for other people rather than thinking about and listening to the experiences and opinions and preferences of and recognizing the diversity that exists or the heterogeneity that exists within the older adult group. So, like, is there a negotiation that can be done in order to maintain people's agency and you know, autonomy, while also recognizing the need for collective action? And just to follow up on one of Liat's points in terms of, you know, there seems to be like a disconnect between and across different disciplines, you know, physicians being trained to look at sorry, I just finished a lecture on psychology of aging, but looking at chronological age as a biomarker, right? And being part of that as the worldview of a physician, when if teams were multidisciplinary, if there was more collaboration with different people with different expertise, including older adults with their own lived experience as expertise, these types of issues would be identified in the planning stages before the implementation of some of these anti-ageism campaigns that are being put out. And I think if there was more collaboration across disciplines in that way, and bringing in the opinions and preferences of diverse groups of older people, I think some of the missteps that we saw during COVID could have been prevented or at least attenuated a bit.
Okay. Let me ask both of you one last big question, and then we'll see if the audience has any further questions. I assume there must be measures of how much, or to the extent, older people accept ageist attitudes themselves. maybe there are scales where you would check to see how much an older person himself or herself or their self accepts these stereotypes. Do you think any of that would likely change as a result of the pandemic? And do you have a thought about which direction it might go? This I recognize as maybe a little speculative, but do you see older people changing their own ideas about? I think I was just muted. Do you see older people themselves changing their ideas about the appropriateness of ageism as a result of the pandemic? Sorry if that's a little bit out in left field of a question.
I can say that I can guess that older people and also younger people are going to internalize pretty negative messages about old age that have flourished during the pandemic. And we know that these negative messages, once they penetrate your mindset, you live by them and they determine your aging process. So I think it's going to affect both young and old people for a very long time, actually.
So you predict more ageism, not less.
Yeah.
Okay, Brad?
I predict more and less
Okay.
in terms of different groups, right? I think people who, if we're talking about implicit types of psychology where we internalize these connections between aging and death and disease and COVID, like those cognitions are being more closely tied. And I think that will manifest in itself in more stronger negative stereotypes. But I think that there's also been a resistance, an acknowledgement of ageism as a social issue and a resistance against it. And I think the pandemic has also elicited that more so than maybe people have previously understood ageism as a social problem. And as a result, like there are grassroots, groups that are collecting, that are resisting against this idea of some of these assumptions being made among older people during COVID, but also generally, right? And there are, coalitions and groups, and the UN has put out a statement in terms of the rights and privileges of older people in general, but also during. So there's this awareness and recognition and stronger levels of advocacy that I think among people who are attuned to that will think more critically about explicit forms of ageism and hopefully be more willing to interrupt it if they observe it in their social environments as well. So I think in some people we will see an intensified version of ageism and younger to like across the lifespan. But I think that there will be also a larger group of people of also any age that are more aware of ageism and more willing to resist against it.
Okay, thank you. All right, well, we are in our last 5 minutes, and I would love to open up the discussion a little bit to anyone in the audience who has a question. You could use the chat. You can raise your hand with our wonderful icons that we have with Zoom, or just give us a signal of some sort if you'd like to address a question to either of our speakers. Do we have any questions? I might put somebody on the spot since I see one of our students in epidemiology from the University of Pittsburgh is on the call. Brianna, do you have a question? Well, maybe not. Okay, anyone else have a question?
I don't have a question. I wanted to thank you, and I also wanted to invite people to a webinar that we're having tomorrow.
Oh.
I can I can give the link, and if people are interested, we have a webinar on ageism and kind of bridging between science and policy. So
Oh,
I will send the
okay.
link to people.
Put that in the chat, and we'll send it around. Okay.
If I may as well, I'd like to plug the Canadian Journal on Aging is putting out a special issue on COVID-19 as well. And That'll be, some of the articles that will be part of that special issue are already available online. But the hard print special issue will be available in December. So if you want some Canadian and international context with COVID research that's going on in Canada, then please do check out that special issue.
Great. Okay, we have a question from Carolyn Ham. Do you want to unmute and go ahead?
Hey, hi, I'm Carolyn from Washington State here in the US. So one of the issues that I think has really been exacerbated during the pandemic is the separation of people in institutional care from the rest of the community. And are there ways that you think that we can counteract that as now we start to come back? And hopefully, you know, after Delta variant stops giving us all these outbreaks, you know, that we start to open up these facilities again. How can we help to reintegrate people living in institutional care with the rest of the community?
Please, anyone have a thought?
Leah, did you want to?
I can just say that at least with the vaccines, I think it's quite, or at least it is easier to do things like that. And to integrate, I can say that in Israel, after the first wave that was quite brutal and all the people in residential facilities were really locked down for months, there were some guidelines that were issued by the government and really did not allow to keep older people in residential facilities socially isolated when the rest of society is not. And these facilities had to follow these guidelines, and it didn't result in a surge of infection. So I think that there is a way to balance physical safety and mental safety, and mental health is just as important here. I can say that we were conducting a research study unrelated to COVID during the pandemic in long-term care settings, and the settings actually really wanted us to get in, even when the rest of the country was in lockdown. The social worker that was conducting the study was allowed to get into the facility because it was so clear to the management at that point, it was already the second or the third wave, that they just have to open up to allow some contact with the outside world, even at the risk of an infection to some people.
And like from a Canadian context, like most of our deaths occurred within long-term care, and the conversation that happened about long-term care was, we've been talking about these health system level issues for decades in Canada, where long-term care it's not an enriched environment for people to live. It's really quite hospital based, and there was a lot of neglect and very poor conditions, and that's an understatement in terms of what long-term care was like in some places in Canada. And so my thought would be, if we want to think about reintegrating, you know, older people in long-term care, we need to think about integrating long-term care into the community rather than separating them as distinct entities or distinct environments. These are institutions, these are homes, right? Supposedly people's homes that are part of the community, but there's for some reason thought of being separate. Also, in terms of how healthcare is delivered in there, you know, the fact that different healthcare workers are going to different long-term care settings, well, that helps spread the virus in Canada, and I'm sure in other countries, but it also, from a relational perspective, right? It's hard to form bonds with people who are in your environment, and in this case, your care provider, if they're rarely there, if different people are coming in. So how can we make long-term care an enriched environment that's part of the integrated within as part of the community? That's a way to address the mental health issues generally that are associated with long-term care, let alone being isolated due to a virus. So it would attenuate the risk of the virus, which would allow for more integration, but rethinking healthcare and long-term care reform will prevent these issues in the future, rather than just addressing the issue that has resolved, that is currently resolving with COVID, right?
Okay. Thank you, Brad. Thank you, Liat. Our time is up. We have a few questions coming in on the chat, and unfortunately, we're not going to get to them all, but we will continue the dialogue on October 12th on our fourth COVID conversation. And one very interesting thing came up in the chat about ageism and perhaps vaccine hesitancy. We can think about that for the future. I really want to thank everybody for a very productive conversation. The webinar will be archived and you can view it on the GSA website. If you have questions for me or our speakers, feel free to email. And really appreciate everybody taking an hour out of their busy days to participate across the world this time. So wonderful. So I wish you all well, and we're going to close our webinar today. So thank you again, everybody. Goodbye now.
Thank you.
Thank you.
Thanks.